Thank you for having me, and thank you all for being here. We're going to talk about how to avoid and treat narcotic dependence in our IBD patients. So I do want to just disclose that as a psychiatrist, I am going to talk about some off-label medications for our non-opiate options. So ever since pain became our fifth vital sign, the rates of opioid prescriptions in the United States went skyrocketing, and related opioid related deaths were on the rise. And this was all happening over a decade, so this is data from 2000 to 2014, without any clear evidence that the opioids were actually useful in treating chronic pain. When we look at all of the evidence, so across all non-cancer chronic pain syndromes, there is some efficacy for use of opioids in some neuropathic pain syndromes and for chronic back pain and headaches, but there has not been any randomized controlled trial study confirming that there's any role for using long-term opiates in the efficacious treatment of chronic abdominal pain. We all know the risks. I'm going to remind you of some of the risks. These risks are drawn both from the general literature on chronic opioid use across different patient populations and the trial that was looked at for Crohn's disease. So physical dependence, addiction, and we'll talk about what addiction is different from physical dependence, overdose, death, and in our Crohn's patients, increased risk of serious infections. Tolerance, so tolerance means that you need a higher and higher dose to get an effect. Opioid-induced hyperalgesia. So we're having a growing recognition that 10 to 15% of patients on chronic opioids, the analgesic effect at the mu receptor turns to a hyperalgesic effect and actually leads to increased pain. When it's abdominal pain, we actually, in the Rome 4 criteria, call it narcotic bowel syndrome. So what I thought I would spend the rest of the time doing is really showing you the evidence-based approaches and focusing on the chronic pain column here and walking us through how would you treat chronic pain with folks who come to you on opioids, who have an addiction problem, and those who don't have an addiction problem. So what is addiction? So addiction is psychological, so it's beyond just the physical dependence on opiates. Any of us who would be put on opiates for a long enough period of time would get physically dependent. Our own endogenous opioid mechanisms stop working, and when you take the substance away, you have physical withdrawal. Addiction is when you have an inability to abstain, you have impaired behavioral control, you're seeking, you're craving the opiate. Craving actually now is thought to have a genetic basis, and you have a inability to see the problems that the opioids are causing in your life, with behaviors, with your relationships. Often there's a dysfunctional emotional response, irritability, anger, depression, and again, these are progressive effects and can lead to fatality. Lots and lots of accidental opioid deaths from prescription medication, so not just the heroin and meds on the street. Some of the risk factors for addiction. So still largely biological, genetic, runs in family. Patients who have mood disorder, both depression and bipolar disorder, much higher risk for addiction. Early use of drug, early availability of drugs, so during childhood and adolescence, and then the environment providing reinforcing factors. When clinicians are considering the use of opioids for chronic pain, here are some of the general risk factors to consider that really will be predictive that your patient is at much higher risk for addiction. Central pain syndromes. So these are patients that come with abdominal pain and fibromyalgia and chronic headaches, pain in multiple parts of the body. Psychiatric the mood disorders, actually anxiety disorders. If there's any suicidal ideation in your patient, there's an increased risk that the opioids will actually lead to overdose. Any substance abuse, and that includes cigarettes as well as cannabis use, a family history of substance abuse, a trauma history, especially severe childhood trauma, and then problem behaviors. Even if they're not due to opioids, again, signs of impulsivity, signs of poor decision-making can be exacerbated, or again, these patients are increased risks for these behaviors on opioids. What do we know about opioid use in IBD? Well, I think that it's used appropriately if it's acute after surgical resection. The addiction medicine criteria for treating acute pain with opioids is 14 days. After 14 days, most patients should be able to come off those opioids and be able to manage their pain in other ways. 5 to 21% of our patients in outpatient settings are on chronic narcotics, so narcotics greater than 3 months. 20 to 70% of our inpatients use narcotics. This could be short or long term. The risk factors for the chronic narcotic use, Crohn's disease, history of substance abuse, a psychiatric diagnoses, irritable bowel syndrome that's comorbid, a history of trauma, and female gender. So you see some of the same criteria coming up, and all of you as gastroenterologists thinking, what's the mechanism you're going to use to screen for these potential problems in some way. Now, it is very interesting because as a group, gastroenterologists are not the predominant prescribers of opioids. In fact, in the United States, in one study, we prescribe less than 3% in the field of gastroenterology. Comes mainly from the family docs, the pain docs, and the ER departments. So what do we do with chronic pain and no addiction? So whenever possible, you want to consider an opioid taper. You want to consider a multidisciplinary approach to the team approach to treat the pain, and you want to use non-opioid drug alternatives. I'm going to go through in more detail, again, what are the empirically supported routes for each of these options. If your patient comes to you on opioids, or if you're prescribing opioids, even short term, increasingly across states, and I think this is now a mandate in 40-some of our total states, that there's a prescription drug monitoring program. In Pennsylvania, it is now mandatory if you prescribe opiates to look up your patient and make sure that they're not getting opiates from any other sources. Random toxicology screens, having opioid treatment agreements, so having your patient sign a contract, making sure that they're aware that you're not going to do early refills, communication with other providers, and making sure that you are reviewing and documenting that you're tracking that there is pain relief and not serious side effects from the opioids. There are risk management assessment tools out there, screeners for opioid misuse. The SOAP-R, the COMM, C-O-M-M, are well validated, the ABC. Having something like that available, having a packet available if you are prescribing opiates, and making sure that you're documenting these steps. Something that just came out a couple of weeks ago is that if we are prescribing benzodiazepines to our patients, so those are things like Ativan, Valium, Klonopin, we now are mandated to check if they're on opioids and to report and to also go to that prescription drug monitoring program and show that we checked in. So this is new, and again, I think shows how nationally, how seriously the country is taking opioid addiction. And basically benzos and opioids together exacerbate each other's side effects, and really exponentially by rates of 5 or 6 times increase the risk of accidental overdose. There are guidelines published by the CDC, so again, if you prescribe opioids even occasionally, really important to be familiar with these guidelines, and they're available very easily online. So we're talking about our patients now on opioids with chronic pain and no addiction. We still want to taper them. We want to be very mindful of withdrawal, especially patients who are on morphine equivalents of 80 milligrams or higher, very high risk for very serious, unpleasant withdrawal. If our patients are on immediate release opioids, considering the more extended release opioids, and then with the reduction, this takes a solid relationship with our patients, and we're talking about a 10 to 20% reduction every 24 to 48 hours is tolerable to patients with monitoring. You can negotiate to go with a slower rate. I think it's a lot of dialogue with the patients, and again, talking up the risks. Remember, if benzodiazepines are sometimes used, and there's documented literature about their use, helping patients with the anxiety of the withdrawal, just remember the FDA warning. And alpha agonists like clonidine can be very effective. And when I am helping a patient come off opioids, I'm giving them clonidine at a very small dose, 4 times a day, something at bedtime. It really does help with the physiological symptoms of withdrawal. There was one study done by Dr. Drossman and his group at UNC. These were patients with narcotic bowel syndrome, so the centrally mediated hyperalgesia, and there were IBD patients included in this group. It's a small group, 37 patients, showed that with a short-term detoxification, and this was done inpatient, that you could actually successfully get patients off their opioids, and they had less pain reports, self-reported pain, not more. The problem with this is that there was no long-term monitoring, and so about 50% of the patients without monitoring and ongoing behavioral interventions will go back to opioid use. So you really have to think about the post-taper plan as much as you are getting them off the opioids. So let's run through then some of the both pharmacological and behavioral ways that we can manage chronic pain in our patients without using opioids. So as I already mentioned, the doctor-patient relationship, the trust is really, I feel, one of the most critical elements. Education about the functional causes of pain, the way that the brain and the gut work together, and how important it is to treat what's going on in the brain and that we can use other means besides the opioids. Multidisciplinary, so the nurses need to help. If you have behavioral experts, social workers, psychologists, very critical time to bring them in, either in your clinics or from the community. Framing this as rehabilitative. So the goal here is not necessarily curing your pain. If you have chronic pain, we can't promise that, but helping you cope with it, improve your functioning despite the pain. Very important to treat comorbid disorders that we can treat, depression, anxiety, sleep disturbance. In terms of the pharmacology, antidepressants and anticonvulsants have the most support, and that's largely drawn from our literature from irritable bowel syndrome, as well as from other chronic pain syndromes, mainly the neuropathic variety. Cognitive behavioral therapy of the behavioral interventions has the most support. So the classes of antidepressants most used are the tricyclics and the SNRIs. Interestingly, the studies for abdominal pain, medications that have some noradrenergic component help the pain most. The SSRIs are very effective for anxiety, depression, which when you treat those, patients can deal with their pain better, but they don't have evidence to show that they have a strong direct effect on the pain itself. Our mood stabilizers, gabapentin, pregabalin, carbamazepam, lamotrigine, topiramate. Quetiapine is a mood stabilizer. It's also an atypical antipsychotic. There's some case reports of efficacy, and actually we have found in writing up that quetiapine can be very helpful for cyclic vomiting. Titrating one psychotropic medication at a time, starting at the lowest dose. Pediatric doses can sometimes be very effective. Often our patients who have been on chronic opioids are very sensitized to the side effects of other medications. And again, try titrating slowly and to endpoint or tolerability of side effects. And really having a way you're monitoring these medications. So only continue them if there is truly a significant evidence for pain relief. Polypharmacy, so we do combine these agents, but again, only if we have at least a partial response in the first agent. As we pile these agents on, they have synergistic side effects that we want to be mindful of. And of course, behavioral interventions, anytime you're prescribing a psychotropic, automatically we should be recommending behavioral therapy to our patients. Cognitive behavioral therapy, so we use that term a lot. Hopefully you're hearing this a lot with GI patients, helpful for anxiety, depression, chronic pain. What are we doing with cognitive behavioral therapy? We're teaching patients coping strategies to think differently, to help with their feelings, to reduce behaviors, and then also secondarily, when we target thoughts, changing behaviors that improve mood, we actually can reduce the physical sensations, pain, poor sleep, muscle tension, and fatigue. There's evidence for cognitive behavioral therapy. Wonderful reviews out here. This is one from Nature Reviews, mainly drawn from irritable bowel syndrome. And again, these are specifically CBT for chronic pain. Hypnosis is another modality, teaching our patients way to put their mind in a different place. Physiological neuroimaging correlates that this different state changes brain metabolism and is efficacious for chronic pain and can have lasting results for up to 4 to 5 years. Mindfulness treatments, so helping patients again put themselves in a different state of mind where they are just letting things go. It takes training, and this can work beautifully, but you have to have motivated patients who are willing to practice these skills. And again, there are small trials, but we're starting to develop efficacy for chronic pain and abdominal pain. All right, for the last part, let's talk about when you have chronic pain and patients with addiction. So we need to treat both. We can't just go on focusing on the chronic pain. We need to reset patients' expectations that they can be on opioids, and again, the multidisciplinary team approach is critical. Obviously, in GI, we don't have this capacity, but it's so critical that you think about where you can refer these patients or again, work with a mental health specialist, drug counseling, Narcotics Anonymous. You can suggest removing contextual cues related to their opioid use, even prescription drugs, getting family members, caretakers involved, and motivational interviewing. So you can be the beginning of the patient's recovery from addiction, getting them used to coming off and the idea of coming off their chronic pain meds. We do have some partial opioid agonists. Buprenorphine is one at a low dose. It acts as an agonist, as at a higher dose, mixed effect. And again, these medications are in the pipeline of development, and you need a special license to prescribe, but just important to know that medications like this are out there, and they can have some mild to moderate effect on the chronic pain. We have multiple patients in Pittsburgh that are on buprenorphine, and that's the medication they're using for their pain. And in fact, access to buprenorphine in the ER has shown now more and more studies that it's decreasing engagement in additional treatment and reducing self-reported illicit opioid use. There's new medications on the horizon, longer acting medications, medications that are mixed opioid agonists, antagonists, and there are vaccines that are in development for patients who have chronic pain and addiction. And then the endocannabinoids is an area of huge research development. So I think in the next decade, we're gonna have a whole new armamentarium of agents to use. Last but not least, and this evidence is really not strongly from gastroenterology, but for other chronic pain syndromes, we have nerve blocks, infusion pumps. And then I think the hottest area in chronic pain management are direct brain stimulation techniques that are being helpful for other chronic pain syndromes. Thank you.